Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us for today's program. Safe sleep, you can do it, we can help. Our objectives today are to list and describe the causes of sudden unexpected infant death, SUID, during sleep, identify and describe the components of a safe sleep environment, outline recommended public health policies to reduce the risk of SUID during sleep, describe the medical and health policies recommended to reduce the risk of SUID during sleep, and to list examples of state-specific efforts that support safe sleep. So before we get into things today, as usual, a couple of reminders for you. If you have a question about anything being discussed today, please call or email our faculty presenters during our live broadcast. The 800 number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Nurses, those of you watching for continuing education credit, I am required to tell you the following. The ADPH is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, continuing education credit will only be awarded for 1 year from today's date, which is April the 30th, 2014. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. ADPH does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. As a reminder, the content of this program is based on the policies and procedures of the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by ADPH should always check to clarify whether the content is accurate according to the statutes, regulations, and policies of your prospective jurisdiction or agency. I'm Samaria Dunson, and with me today is Dr. Mary Wagner, Director of the Pediatrics Sleep Program at the University of Florida, and also Dr. Catherine Wood, who is with Partners in Pediatrics here in Montgomery, Alabama. Thank you both for being here. Let's get started.
Okay. All right. We ready?
Yes.
Okay. All right. So I'm going to talk about safe sleep recommendations, policies, and recommendations, particularly based on what the American Academy of Pediatrics has recommended. And I'm going to use a document that was published in 2011, which was an expansion of a previous document in 2005. The 2005 document really dealt primarily with SIDS, or sudden infant death syndrome, and the 2011 expansion also takes into account a newer term, sudden unexpected infant death. And this is important because while the risk of SIDS has decreased, it is still a leading cause of death in infants. And at the same time that SIDS has decreased, SUID has actually increased. So if we take a look at the comparison between SUID and SIDS, SUID during sleep is what we're going to focus on in terms of safe sleep. And there are a number of potential causes of sudden unexpected infant death during sleep, which are listed here, including suffocation, asphyxia, entrapment. Some of the causes are more poorly defined and nonspecific, and we're going to talk about some of those causes and ways to create a safe sleep environment to prevent these things from happening. This graph here reminds us that the risk of sudden infant death syndrome actually dropped after the Back to Sleep campaign was instituted in the United States in 1994. And I don't know if you guys can see that, but in fact, what we can see is in 1994, the blue bars are showing us the risk of sudden infant death syndrome. And if you look at the top of the graph, you'll see the red triangles. And those red triangles actually represent the percentage of children that are put to sleep in the non-prone position. We would like that to be the supine position. And as you can see, as positioning children in the non-prone position went up, the risk of SIDS went down. I think you can also notice as after a fairly dramatic drop, that risk of SIDS has actually plateaued. And we're going to address that as well. And that's why it continues to be a concern to the American Academy of Pediatrics and to pediatric caregivers and other stakeholders. Here's the article in the Journal of Pediatrics, which expands the information about sudden infant death syndrome, including sudden unexpected infant death during sleep. And it's the basis for recommendations. And there's also an accompanying report that's called, actually, in addition to recommendations, the technical report that has all the background and the evidence for these recommendations. Okay? So if we take a look and remind ourselves what SIDS is, SIDS is the unexplained infant death after a thorough case investigation. That case investigation needs to include an evaluation of the death scene, an autopsy on the infant, and also a history review for relevant findings. And it's also assumed that the child died unobserved and during sleep. So those two things, because the child was unobserved, are assumed. While sudden unexpected infant death is death of an infant that's explained or unexplained and also incorporates and includes SIDS deaths. SUID also requires a case investigation, and one of the differences is that SUID really focuses more on potential causes. The distinction between SUID during sleep and SIDS can be very difficult, but there are similar risk factors for these groups of infants as we've been keeping track of the risks and the actual incidence of these things happening. Usually SUID is attributed to some etiology after a thorough investigation, and those etiologies include suffocation, asphyxia, entrapment of the infant, but they can include other things as well, including ingestions, infections, underlying metabolic disorders. They also include arrhythmias or other cardiac issues, and trauma, and that's both accidental trauma and non-accidental trauma. One of the reasons that the American Academy of Pediatrics revisited this is to actually continue to try to work to reduce the risk of SIDS, but also to reduce the risk of sleep-related sudden unexpected infant death. Because as we've seen the risk of SIDS go down, we've seen the risk and incidence of SUID go up. The recommendations are aimed at a variety of stakeholders, including parents and caregivers, and those caregivers include grandparents, babysitters, daycare center. Future parents, and that means immediately future parents, but also it's aimed at educating our youth so when they become childbearing age that these recommendations aren't so foreign to them, but also healthcare providers and infant advocates. And then the other group that we're interested in educating are our health policymakers. So we're making appropriate health policy to try to decrease the risk of infant death, whether it's SIDS or SUID, and also our researchers, so we continue to investigate why we're losing children to this on an ongoing basis, and that we haven't eliminated these deaths. The safe sleep recommendations from the American Academy of Pediatrics apply to children up through 1 year of age. So that's important. And they are based on epidemiologic studies and case control studies. There is no way to do randomized controlled trials to investigate some of the recommendations, and the strength of the recommendations vary. Highest level are level A, and those recommendations are based on good, consistent evidence with a very high certainty of net benefit for that particular recommendation, that it is going to do more good than harm. The next level is level B. In level B, the information or the evidence is a little bit less consistent or limited, but it still suggests that there's a net benefit in outcome. The caveat is that if more information is later gained, that this recommendation may change. The lowest level, or level C, is based on consensus or expert opinion. So as we take a look at the recommendations, we'll keep in mind what the level of that recommendation is, and that's based on the information that we have. So level A recommendations, these are the ones with the most consistent, strongest information, and probably at the top of that list is back to sleep for every sleep period. That means putting the child to sleep in the supine position through age 1 year. There has been concerns raised that when we put kids in the supine position, there may be an increased risk of choking or aspiration, but that actually hasn't borne out at all. And then even if a child has reflux or gastroesophageal reflux, unless the physician has determined that that risk of reflux is greater due to an impaired upper airway protection, that would outweigh the risk of SIDS, then that child should still be put back to sleep. Okay? Such an upper airway problem might be a laryngeal cleft in a child who hadn't had anti-reflux surgery. So the point is that it's very unusual for children to have such a severe problem that they should not be put back to sleep. And in fact, the National Association of Pediatric Gastroenterologists endorses this as well. The other group to remember is that this does apply to preterm infants when they're stable. When preterm infants are born, they're usually put in a prone position because that stabilizes the chest wall. But as soon as they are stable, they should be moved to a supine position, and this should occur a long time before they leave the NICU or the nursery for a couple of reasons. One is to make sure that the infant gets used to sleeping in the supine position, but it's also to model behavior for parents. So when parents take that infant home, they know the appropriate sleep position is supine as it was in the nursery before they left. Some people have advocated elevating the head of bed for kids who have reflux. This should not be done because it actually does not work. And when we elevate the head of the bed, either on blocks or with a wedge, the kids will slide to the bottom of that elevation, and then they'll be in a compromised position. So they don't recommend elevating the head of the bed. And also, side positioning is not recommended. Side positioning is the same as prone positioning in terms of risk of SIDS. Initial thoughts were that children need to be placed in the supine position shortly after birth to help them clear amniotic fluid, but this truth has not been borne out, and it doesn't facilitate the clearance of amniotic fluid. And in fact, when children are placed in a bassinet, they should be placed in the supine position, again, so the children get used to that position and so that we're modeling good behavior for our families and their caregivers before they leave the hospital. When an infant can roll, they are allowed to maintain their chosen sleep position. So parents do not have to go back in throughout the night and keep putting the kid back in the supine position, because that has to do with their strength and their ability to hold their head up and stay out of trouble when they're asleep. So no, you don't have to keep going back to the bed and turning them back over on their back once they can roll to their stomach. Additional level A recommendations deal with the sleep environment, specifically the sleep surface. The mattress should be very firm and the sheet should be fitted, and that should be whether that mattress is in a crib, a bassinet, a portable crib such as a pack and play, and all those sleeping arrangements need to meet current safety standards. Should make sure that they aren't using older equipment with recalls, missing parts, or broken parts. In some instances, local groups can help provide for those who have limited resources. Dr. Wood's going to address this specifically in her talk. Back to the mattress, though, it's very important for the mattress to be firm, and it needs to fit the crib very well with no gaps between the crib slats and the mattress, because this increases the risk of entrapment. And again, the cover on the mattress, the sheet, should fit very tightly. We shouldn't be wedging pillows, comforters, or sheepskins in between the sheet and the mattress, because that softens the surface. So again, no pillows or cushions, not only in between the sheet and the mattress, but children should not be put down to sleep on pillows or cushions, either in the crib or outside the crib. Additionally, they shouldn't be put down to sleep on top of quilts, sheepskins, or comforters, because again, this is a soft surface, increases their risk of actually getting entrapment and also rebreathing and not being able, and suffocating. All right. The other thing that's really important is that children should be sleeping in a crib or a pack and play, and they should not be sleeping in a regular bed, either alone and especially with adults. Sleeping in a regular bed with those portable rails that we sometimes put on the edge of a bed that keep older kids from falling out should not be used in infants, because those portable bed rails are an entrapment risk for infants, and then also a strangulation risk. So a regular bed with those portable rails is not appropriate for an infant. The other thing that we need to do is make sure that the child is sleeping, the infant is sleeping in a hazard-free local environment, and by that I mean that there is no dangling cords, wires, no cords from the drapes, no cords from a lamp, anywhere within reach of that crib, so the infant is sleeping in a hazard-free environment. I think the other thing that we see infants doing quite a bit that people need to realize is that children should not be sitting in a sitting device for sleep, such as a car seat, a stroller, an infant carrier, or a swing. All right? So once kids fall asleep, we can't help kids from falling asleep in that situation, but then they should be moved to a regular crib. The other thing we need to make sure of is that we aren't putting sleeping infants in a car seat on top of a crib or another surface, because there's a risk of that car seat rolling over, and then the kid would be entrapped and also has an increased risk of suffocation. We shouldn't be using these kinds of seating arrangements instead of a crib, whether at home or in the hospital. So they shouldn't be sleeping in these things in the hospital either, in infant carriers or car seats.
That's really good information with regard to the swing, because sometimes the only way to get them to sleep is to put them in that swing.
Right, and the next slide will demonstrate, I believe, a couple slides, why this shouldn't happen.
Okay.
Okay, so I actually have a picture of that. This is particularly important for the younger kids, less than 4 months of age, and the reason for that is they have poor head control, and they have a relatively large head compared to the rest of their body, and they are at risk for compromising their airway with upper airway obstruction, and then at risk for suffocation. We also see families using lots of slings or baby carriers, and so when the child is in a sling, the head should be above the material of the sling, the face should be visible, and we need to make sure that there's no obstruction to the nose and mouth because if they fall asleep in a sling. Again, if they fall asleep in a sling, we are supposed to move them to a crib once that crib is available. They're not supposed to sleep extended period of time there. So when children fall asleep in their car seat, their swing, or in their sling, they should be moved to a crib when possible, even if they fall asleep in a sitting device. And here you can see what can happen to kids in a car seat or a swing, that they are unable to maintain head control, and you can compromise their airway and increase their risk of suffocation. And we certainly wouldn't want that to happen. Another thing that's strongly recommended by the American Academy of Pediatrics is room sharing, yes, bed sharing, no. Bed sharing is a big no-no. So we put the crib or bassinet in the parents' room, and that is felt to be important so the parents can monitor the infant. And we also don't recommend bed co-sleeping devices because we can be uncertain about how well they are connected to the bed and how well we can make sure that the kid stays in the co-sleeping device versus the bed. The other thing that's important to remind our families about, if an infant is brought to the bed for feeding or comforting, once that is over, the baby needs to go back to a separate safe sleep space. Okay, and that really needs to occur before a parent falls asleep. There is no evidence that putting the kid back in a separate environment is any impairment to breastfeeding, which is a common argument in this case. Okay, so remember, our new moms may be very sleep deprived, and that is a risk factor when we have very sleepy adults in the same sleeping environment with an infant. A huge problem is falling asleep with an adult in a couch or an armchair, and this is a huge risk for suffocation, so sudden unexpected infant death related to suffocation, particularly if that adult is at a high risk of falling asleep. So if they're falling asleep, the kid can get trapped between the adult and a couch or an armchair cushion and suffocate before the adult may actually realize that. There are no demonstrated bed sharing situations that protect children from SIDS or SUID. There are a number of cultures where co-sleeping is fairly common, and there are a number of cultures where co-sleeping is common and the risk of SIDS or SUID is not high. That is felt to be related to the sleeping surface. So those are environments where they may be sleeping on the floor on a mat or a very firm surface. There's other cultures where co-sleeping is very high, where the risk of SIDS is also very high. So there is, as I said, no demonstrated bed sharing situations that are protective for kids. Right? So we have to remind our families of this while we're still sensitive about what culturally is going on in their family. Particularly at increased risk are infants who are less than 3 months of age, so our younger infants, infants who are sharing a sleep environment with a current smoker, all right? Infants of mothers who smoke during pregnancy, if they're sharing a bed space with an adult who's tired And what adult who takes care of a 3-month-old infant
Absolutely.
is not tired, right?
Yeah.
They're all tired, right? The other thing we need to be aware of, adults who've been drinking or using sleeping aids, which alters their level of perception, are also an increased risk of SIDS. So we have to ask about these things. We don't really want co-sleepers or sleeping in an armchair after we've had a couple of beers, or somebody that's having trouble sleeping and they take an Ambien. Because a lot of folks will tell you once they take that sleeping medication, they don't remember much. Other particular bed sharing risks are if that infant is sharing a bed with a non-parent, and that includes siblings. If there's multiple people in the bed, and if we're on soft bed surfaces. So they shouldn't be co-sleeping at all, but definitely should not be co-sleeping in a water bed or on an old couch because it's softer. There should be no soft materials in the bed, such as pillows, blankets, and quilts. Although they're cute, they actually represent a significant risk for infants for suffocation and entrapment and even overheating. The other thing that we need to remind our families about is that there should be a separate space for children of multiple births. So our twins, triplets, quads should be in a separate space. And when they're not in a separate space, they're more likely to be placed in a non-prone position. And as you can see in this example, there's a lot of extra material in there. There's a risk for suffocation with these situations. And certainly on the lower right, we don't want to be in that situation either, where there's like way too many people there. Back to our sleep environment, there should be no soft objects, loose bedding in the crib. We shouldn't have stuffed animals in there. We don't put pillows in there, no comforters, no toys, no quilts, no sheepskins, and no crib bumpers. So crib bumpers were popularized a number of years ago, and they were popularized and used so that children wouldn't injure themselves on the sides of the crib. New crib standards place the slats so that they're much closer together, so there's no risk of entrapment there. And actually the evidence that crib bumpers protect children from substantial injury are very low. And in fact, crib bumpers present a suffocation hazard if the child gets up next to the crib bumper, a strangulation hazard if the kid gets caught on the crib ties, and also an entrapment hazard if they get caught between the crib bumper and the side of the crib. So they're a big no-no as well. We should have infant bedclothes which provide warmth without overheating or head covering. Okay, so we don't want to overdress our kids for sleep because overheating can be an increased risk. Okay, so warmth without overheating. Okay. Additional level A recommendations are focused on maternal health issues. All pregnant women should get regular prenatal care. I'm sure that's something that Dr. Wood would reinforce as well. And we know that mothers who don't get prenatal care are much more at risk for having low birth weight infants or premature infants, and those two things are risk factors for sudden unexplained infant death and SIDS. Smoke exposure should be avoided pre and post-birth. There should be no maternal smoking during pregnancy and after pregnancy. Additionally, there should be no smoking by others in the mother and infant's environment, whether that's the house, the car, or wherever it is. And remember, I said there's a very high risk of SIDS if an infant is sharing a sleeping space with a current smoker. So smoking is bad. The etiology of that is it's felt to alter some of the brain receptors that deal with cardiorespiratory responses to stress. So there's actually a fair amount of evidence about that. Of course, illicit drug and alcohol should be avoided prior to pregnancy and during pregnancy. And again, other adults who are bed sharing, if they're using illicit drugs or alcohol, it magnifies the risk of SIDS or sudden unexplained infant death of suffocation greatly. Okay, so this is another big no-no, right? Additional level A recommendations that relate to infant care is breastfeeding decreases the risk of SIDS, and it is the behavior that is probably most important, second to the Back to Sleep campaign, as something that decreases the risk of SIDS. While exclusive breastfeeding for 6 months is felt to be most protective, any breastfeeding is felt to be better than none. All right. An additional recommendation that's a little bit more recent is offering a pacifier during all sleep periods. All right. So at the beginning of the sleep period, a pacifier should be offered. All right? It is known to have a protective effect on SIDS incidence, the etiology of which is not really known. Some people believe that maybe non-nutritive sucking helps maintain an open airway, or maybe it changes the child's arousal threshold. And while we offer the pacifier at sleep onset, replacement after sleep onset is not necessary. So families do not have to keep going back in and putting the pacifier in the children's mouth. And at the same time, infants should not be forced to take a pacifier. So if infants don't want to take a pacifier, then you do not have to persist and shove the pacifier in the baby's mouth. And while we recommend using pacifiers at sleep onset, there's a couple rules we need to remember. Is we don't hang pacifiers on a string around on the child's neck or attach them to a leash to the child's clothing during sleep. There shouldn't be any soft items attached to the pacifier because that would be a suffocation risk. And most people recommend delaying the introduction of a pacifier in breastfed infants until breastfeeding is fairly well established. That can vary for different kids, but usually by 3 to 4 weeks. All right? So even in our breastfed infants. And although pacifiers have been shown to be protective against SIDS, there is no known protective effect for children who suck their fingers. Okay? They just do that. All right? Here's a couple of examples of a pacifier with a leash, and the little kid on the right has a pacifier with something soft attached. And while you can use that while they're awake, we should not be putting them in the sleep environment with these kinds of things attached to the pacifier. Overheating is another thing that increases the risk of SIDS. And so we have to remind our families to dress the infant for their environment, and that the infant should probably not have more than 1 extra layer compared to adults. So we don't need to put 7 extra layers on the kid. And that the infants should be monitored for overheating. Are they hot to touch? Are they flushed? Are they sweating? And while we dress infants for sleep, we want to avoid covering the face and the head because we don't want that to be a suffocation hazard. And although we've talked about overheating as being an increased risk for SIDS, there is actually no evidence that suggests putting a fan on the kid during the sleep decreases the risk of SIDS. And here we've got some well-dressed children. All right. An additional level A recommendation is the use of, do not use home cardiorespiratory monitors to reduce the risk of SIDS. This has been fairly popular, sending the kid home on a monitor that monitors both heart rate and respiration. There is no evidence that use of home cardiorespiratory monitors reduces the risk of SIDS. And it does not identify those children in the hospital who are subsequently at risk for SIDS. We do still use home cardiorespiratory monitoring at home for selected infants, those children with proven apnea and bradycardia when they graduate from the nursery. The other group that we use it in are kids who have some kind of an airway problem or infants with chronic lung disease who require oxygen. All right? We also will sometimes place children on a monitor if there's a family history of a sudden infant death syndrome child to give that family some reassurance, although there is no evidence that placing those children on monitors actually changes their subsequent risk of SIDS. Additional level A recommendation is that we continue with a national campaign. That national campaign is continuing to reduce the risk of SIDS and SUID, and with a particular emphasis on the safe sleep environment, some of the things that we've talked about in terms of cribs, environment, back to sleep. We want to reduce the risk of sleep-related SUID that are related to suffocation or accidental deaths. And that this national campaign is aimed at a variety of stakeholders, but we also need to engage our professional stakeholders. Our professionals, our nurses, our physicians, our pediatricians, our family practice people, other primary care providers, so that they will endorse and educate their families about these safe sleep environments, and that they make it a part of their questioning in a prenatal visit, but also when children return for a visit. So we also need to engage others who provide infant care, not just the parents. We also have to educate grandparents who provide a fair amount of care, babysitters, and daycare centers. So there's a fair number of infants that will actually die in daycare. So this is very, very important, is that we are educating anybody who might be taking care of that kid. And we know that infants spend a lot of time asleep, even during the day. So we have to educate our caregivers during the day, whether it's grandma, grandpa, babysitter, or the daycare center. We also need to try to overcome barriers for behavioral change, and that would include all care providers, whether it's grandma, who has lots of information and she remembers what it used to be like. We also need to focus on groups who have higher SIDS risk and SUID risk, and those groups include African Americans or blacks, American Indians and Alaskan Natives. People have tried to figure out what are the particular issues that make these groups at higher risk of SIDS or kids dying from SUID. And they seem to be related to breastfeeding and increasing breastfeeding in those groups, decreasing bed sharing, and also elimination of tobacco smoke exposure. And the other thing is making sure that these groups get the message that the children should be put down to sleep in the supine position for every sleeping period. We need to educate all of our stakeholders about how to avoid risk factors, and that includes prenatal education for our parents who are about to be parents, but we also need to get this into secondary school curricula as part of routine health practices. So this isn't new information when people are coming of the age when they are actually thinking about and having children. And the topics will include the importance of prenatal care, because we've already talked about lack of prenatal care as an increased risk for SIDS, but also including avoidance of substances such as alcohol, tobacco, and drugs that make these kids at increased risk in the perinatal period, and also stressing safe sleep environments. How do you create a safe sleep environment at your house? How do you not, what things should we not be putting in the crib? What should our crib be like? They also recommended that these recommendations be reviewed, that we don't just put them out there and leave them out there. They need to be reviewed, revised, and reissued with pertinent messages every 5 years. So we can take a look at if there's a particular group that's having difficulties, how do we need to focus on that group, to re-educate that group, to make sure that we are continuing to reduce the risk of SIDS or SUID. Level B recommendations, and remember these are recommendations where the information is a little bit less consistent, but it's still felt that the recommendations result in a net benefit. One is related to infant health, and that infants should be receiving well child care according to American Academy of Pediatric recommendations, and that they should also be receiving appropriate immunizations as recommended by the CDC and the American Academy of Pediatrics. Immunizations are actually felt to be protective against these problems, and there's no causal relationship between immunizations and SIDS. Okay, so there's been some suggestion of that in the past, but those studies have not borne out, and actually well-organized studies do not show any evidence of a causal relationship there. I think another thing that's really important that we ask our families about is that we avoid positioners that are specifically marketed to reduce SIDS. And those include wedges and positioners, special mattresses or sleep surfaces. And in fact, some of these positioners have been linked to actual suffocation deaths. Some of these positioners that were actually marketed to reduce the risk of SIDS. There's no evidence that any of these positioners reduce the risk of SIDS. An additional level B recommendation is that children should have supervised tummy time to enhance their development on a daily basis. Not only does this facilitate development, but it avoids what we call positional plagiocephaly, which means the back of your head gets flat because you're sleeping with your head in a supine position all the time. But that's just good for infant development. In terms of infant sleep positioners, there was actually a report in the MMWR in 2012 which reported on suffocation deaths that were associated with the use of infant sleep positioners in the years from 1997 to 2011. So this was a problem that was enough of a problem that the Center for Disease Control actually investigated this. And what they found that there were 13 deaths in this report of November of 2012, and those kids ranged in age from 21 days to 4 months. There was a predominance of males to females. There was a history of a cold in 4, including respiratory syncytial virus in 1. 3 of these families were using these infant positioners to prevent SIDS, and then their children went on to die. All right? So we need to specifically ask our families, are they using these kinds of positioners? Make sure that we don't just expect them to tell us, that we proactively tell them not to use these kind of positioners. Another a level C recommendation includes the endorsement of SIDS reduction suggestions. Again, this is expert and consensus and expert opinion, that our healthcare providers from the get-go, the nursery, the NICU staff, and child care providers, all are following our safe sleep recommendations and are reinforcing these to our families. That we need to educate all these stakeholders about these recommendations so they know what they are, and so that we're modeling this good behavior, whether it's in the daycare center or in the nursery or in the NICU. These safe sleep practices need to start at birth, and so the nursery is pivotal here. So we need to make sure that infants, premature infants, once they're stable, are put down to sleep in supine position, not only from the safety reason, but again to model behavior. So when our families see how the babies are put down to sleep in the nursery, they will do that at home. Okay? Our child care providers should also have safe sleep protocols, and the environment should be assessed to see, is it a safe environment? Are the cribs safe? Do we not have things in the crib? Are the mattresses fitting tightly? We don't use things like cushions, sheepskins, or quilts, and that if the infants are sleeping in an environment, that there is no choking hazards like cords from a lamp or shades within the environment that the kids can get into. The other thing that we need to do is make sure that our media and our manufacturing groups are following safe sleep guidelines in their messages and ads, so they aren't confusing parents by putting children in ads and magazines in non-safe sleep positions. Okay? So our movies, TV ads, and magazine materials need to be following these safe sleep protocols because parents model behavior according to what they see in these media outlets. So not only do they need to display safe sleep messages, they need to avoid messages that suggest behavior that's contrary to safe sleep recommendations. We also, another level C recommendation is that we continue our SIDS and SUID surveillance so we can learn how are we doing with our recommendations, are there problem areas, and that our researchers are looking not only at risk factors and pathophysiology, but they're trying to come up with evaluations and innovative programs so that we can educate hard-to-reach populations, particularly populations that might have a higher risk of SIDS or SUID, so that we are helping reduce the risk of these deaths in these particular populations. It's also important that there's standardized protocols for death scene investigation. That is included in the evaluation of both a child that is lost from SIDS or SUID, so that we are covering the same materials. So that can be very variable depending on what part of the country they're in. There should also be a comprehensive postmortem evaluation that includes autopsy results, specific and pertinent lab tests, and radiographs or x-rays as needed. All right, I think that's it for me. Any questions?
Do we have any questions from the audience?
In the audience.
So my question is, what can we do to encourage our policymakers to back and support their recommendations?
That is a really, really good question. And I think the most powerful way to get policymakers to back these recommendations is not only to educate them about recommendations, but also to have a family voice. Somebody that maybe has had this experience in their past or lost a family member. And I think that's a much more powerful way to advocate for these safe sleep recommendations than just the professional stakeholders. So I think when professional stakeholders are approaching our policymakers, they may not be as receptive as they would be if it was one of the constituents who would probably have a very heartfelt story.
Any other questions from the audience?
I have a question.
Okay.
What about sleep sacks to put babies in? You see a lot of these adorable, cute.
I think you don't want the sleep sack to be a couple things that you want to be aware of. That you don't want it to be so big that the kid could get lost in it, okay? And you also don't want it to overheat the child. So I think those are the two biggest things in terms of sleep sacks and using them in infants. And I think that although you're allowed to use blankets in a crib, the blankets need to be tucked underneath the mattress so that there isn't loose blanket material in the crib with the infant. And so although, yes, sometimes we have to use blankets, they need to be tucked tightly underneath the mattress. And we also want to make sure that they aren't pulled up too far, so we aren't covering the face and the head. And the head is an overheating thing, but also suffocation risk.
Well, I can tell you as a parent of a 3-year-old and a 1-year-old, I've missed the mark on this so far, but I can certainly share it with others. I really tried to go out and do all the prenatal classes, but you're telling me a lot of stuff I really didn't know. I'm the first one to admit that I'm guilty of the swing. You know, when you're a new mom, the sooner you can get to sleep, however they will sleep, you'll take it. So that's really, really good information. What I would like to see happen, I don't know if you have any information on this, is, you know, when you give birth and you're in the hospital, there's a breastfeeding coach that'll come around and teach you all those things. I think it would be great if there was someone who specifically came around and told you about that, because my is that your job?
Oh,
right, okay.
So she's
good.
a straight man. Okay, so Dr. Wood will address that.
Right.
I agree with you, because I think that, I mean, part of this is not just errors of omission or commission, but errors of omission in terms of not specifically asking questions or reminding our families that we actually don't sleep with the baby on our chest on the couch where the baby can roll over. Somebody needs to be paying attention to that, and that we need to have a safe sleep environment, whether it's a pack and play, a crib, whatever it is. There's some simple things that you can do, like back to sleep is very powerful. Breastfeeding is very powerful. Avoiding smoke in the environment. These are all things that people can do, and not putting comforters, quilts, sheepskins, and stuffed animals in the environment with the infant. Right. And that remembering that you saw the picture of the kid in the swing that's kind of, you know, like this with their airway compromised, that is why you should move the kid then to a safe sleep environment. Mm-hmm. And we need to remind the babysitter of that as well.
Right. And the grandparents.
And the grandparents. And, you know, part of it, as in my life as a pediatrician in the dark ages, when I was in the nursery, if the nursery nurses caught you putting a baby down to sleep in the supine position, they would have skinned you alive. That has changed in my lifetime as a pediatrician. Now we put babies down to sleep in the supine position. We have to model that good behavior in the nursery. So we need to make sure that we're paying attention to what these recommendations are, and that we're up to date on that, and we are specifically educating our families about some of these points about what is a safe sleep environment, and that it is their job then to educate the other caregivers, whether it's the daycare center or the grandparents or the babysitter. And then if you're putting the kid in a daycare center or somebody's home for daycare, you need to go see, where is the child sleeping? You, as a parent, are still the greatest advocate for that child, and that you should be the person that's calling the shots, okay? It's just, even if it's grandma. We still need to insist what's a safe sleep environment, because there's not a grandparent or a child care provider that wants any child to be lost because of SIDS or SUID. And so we need to look at the data, and there's a lot of data, particularly about back to sleep, that using that supine position, that's very powerful. And the data has shown that when people sort of back off on the back to sleep campaign and they go back to not reinforcing supine sleep, you see the risk of SIDS go up. And this has been demonstrated in countries around the world. And so we have to continue to figure out what is going on and what are the barriers to following these recommendations, and help families work through the barriers, identify what those are, and help them work through them in a reasonable way. But you have to engage them in discussion and actually ask the question and figure out what's going on, and not just assume. Right. I think that's important, that we don't assume.
And that education is so essential also, because I'm one of the ones who's also guilty of buying those wedges. I was like, oh, anything I can find in Target that I can possibly do for my baby, I'm going to do it. And I got those wedges. And I heard later, once I got ready for the second child, who you'll let eat off the floor, for those of you
That's right.
who have a second child, I knew that that wasn't appropriate. But, you know, you're really just trying to educate yourself on what the best things might be. So kind of this false advertisement really isn't helping things.
And I think we have to be aware that new parents get advice from a lot of different sources. I'm sure Dr. Wood can tell you that, whether it's grandma or Aunt Susie or whoever it is, they're getting a lot of people whispering in their ear. And we have to empower our parents to know these are the safe sleep recommendations. And these recommendations aren't made lightly by the American Academy of Pediatrics. They're reviewed and made sure that they are sound and that they are backed by evidence, and that we empower them so that they are an advocate for their child no matter who's providing care for them, whether it's the daycare center, whether it's grandma, whether it's the kindly neighbor next door, that we are making sure that it is their child and that they need to advocate for, this is my child, and this is how, just the same as you would with discipline, this is how we're going to sleep, and we're going to sleep safely. So I think empowering them to sort of be aware of what the recommendations are and insisting that wherever the child is sleeping, that the environment be safe.
Yes.
We get a lot of questions from parents about a baby who has a very strong startle reflex, who when they're on their back, they startle themselves awake and then cry for long periods of time, and parents get very stressed. In that case, is it okay to put a baby on their tummy to sleep, or still try to put them on their back?
Put them on their back.
Always. The
Yes.
answer
And
is
see, one
always.
of the issues with prone
We get
versus
that question a lot.
And one of the issues versus prone versus supine sleep is that babies do sleep more soundly in the prone position. But the problem with that is that the thought is that children who die from SIDS are sort of an interaction between a vulnerable age, certain stressors in the environment, and something intrinsic about that child where they don't respond like they're supposed to. So one of the issues with putting a kid, they don't sleep as well supine, but they may need to not sleep as well to protect themselves, and so they need to be placed in the supine position, and we might need to get them some help. So if the kid is crying and screaming and upsetting, is that we have another way of helping them deal with that. So that's probably protective. But you could try that argument. But it probably is. That arousal is protective.
And is that a condition, or I've not heard of that before?
Oh no, that's a fairly common thing that when kids startle, they they'll go like that, and the parents are like, "What's going on? Are they having a seizure?" What's going on? It's just a startle reflex.
Okay, and that could happen while they're sleeping.
Yes.
Okay.
Something startles them.
Okay.
There is also
Yes,
as they wake up and then they're fussing, and of course the rule is you wake the baby and the baby's yours.
Yes.
Yeah, so that is still the rule. That is the rule. So you wake the baby and the baby's yours, but we still never want to be in a situation where we're advocating or suggesting that kids get put down to sleep in an unsafe position.
Right. Any other questions?
We've talked several times about the overheating. One of the questions we get quite a bit is, what is a comfortable temperature for infants?
So most people would say a comfortable temperature for adults would be a comfortable temperature for infants, and they might need one additional layer of clothing. Now, my husband used to say, when mommy is cold, the baby gets extra covering. But I think that would probably be not just one adult in the environment, what the general consensus of adults. And so the bedroom should probably not be 85 degrees. It should be comfortable levels, 68, 70 degrees, with one extra layer on the kid rather than multiple layers, head covering, 3 blankets, that sort of thing.
And we get that a lot with the grandparents keeping the infants that may be on certain medications, whether it be a blood thinner, things of that nature,
Sure.
because they're going to keep it warmer.
So then that
Than
kid
what
would have
you're
to have
already
less
doing.
on, right? Fewer bedclothes, no blanket covering them.
I mean, a onesie.
Right, a onesie, exactly, right. Diaper, right?
You mentioned cigarette smoking. Is there any evidence yet about e-cigarettes and their impact on SIDS or SUID?
There isn't, because I don't think they've been around long enough, but remember, e-cigarettes, what they're vaporizing is nicotine, and nicotine is probably the active agent that changes what's going on for cardiorespiratory responses, or maybe even development of some pathways in the brain. So I would just say e-cigarettes fall into that same category. All right, it isn't necessarily the smoke. It's actually the nicotine. I mean, smoke is noxious as well, but what investigators have looked at is the effect of that nicotine exposure. So that's a good question.
Any other questions? All right. Well, if it's okay, I think it'd be a good time to take a break before we continue on with our program. So thank you so much for presenting that information, and we'll see you all back in a few minutes. Welcome back to the Alabama Public Health Training Network. Today's topic is safe sleep. You can do it, we can help. We have with us Dr. Catherine Wood, who is a partner in pediatrics here in Montgomery, Alabama. Welcome, Dr. Wood.
Thank you. Thank you. I think my job here today is to talk about what Alabama has done or is doing to try to promote safe sleep messaging. And I am doing this as a favor to Deanne Jackson, who is in the nursery at UAB. She called and asked me would I be willing to do this today because it was going to be difficult for her to get away. And I said, sure. I didn't quite know what I was getting into because this is my first experience here. I'm not an academician. I'm a private practice pediatrician. And so when I'm filling out my conflict of interest form and they ask me what education and training have I had specific to this educational activity, and I thought, yikes. I'm not an academician. I'm a private practice pediatrician. And then I said, okay, I can do this because really what I do every day is promote health. I've practiced here in Montgomery for 28 years. I've taken care of loads of kids. I've dealt with loads of parents, lots of grandparents, some difficult, but most really lovely. Have had a very fulfilling life in pediatrics. And what I have found through the years is that it is the small things that you do that have the biggest impact. And must be present to win is really, really, really important. You got to show up every day, you got to put the backpack on, and you got to go to work and take care of the little things and be patient because it is something where what you do every day, you do it over and over and over and over, and eventually you have an impact. It's not something that is sexy. It's not something that is risk-taking, but it's very fulfilling. And so through the years, in my 28 years, I've taken care of lots of families, as I've said. I have now got kids who are having kids, so I'm taking care of grandpatients now. And I think the most fulfilling part of my job is developing relationships with families, celebrating milestones, and watching the beauty of the growth of a family unit. And having peers who have raised their children with me and now they have grandchildren. So that's really the joy of what I do. And the terrible thing about what I do is that, and this is fulfilling too in an odd way, but when you lose a patient and you grieve with a family and you feel like there's something that I didn't do that resulted in this baby's death or this child's death, or if I had said this one more time that would have made a difference, that's the hardest part of what I do. So all of that to address this today, because I think anyone who is watching this is interested in caring for children and interested in improving the life quality of a baby and a child and the fulfillment of a family. So there's where I am. I trained in the 80s. My babies were tummy sleepers. Every baby I ever took care of in a nursery, unless they were on a ventilator in a high-risk nursery, was on their tummy. That's just the way we did it back then. I started practicing in 1986, and in 92, I think is when the change was made as far as the recommendations go. So I practiced the first 6 years, telling everybody to put their babies on their tummies, be sure that's the way they slept. And then remarkably, in a very short period of time, all of us could see that the incidence of SIDS dropped dramatically just from doing one very small thing. And so I feel like I've done a decent job through the years messaging that. However, you know, in the last few months after I was asked to talk about this, and you look at infant mortality in the state of Alabama, it is horrifying to think that, I'm not making my slides go forward, sorry. So there's who I am, and here's the uptick in infant mortality. 8.1 infant deaths per 1,000 children in Alabama in 2011, 8.9 infant deaths per 1,000 children in Alabama in 2012. That's horrible that we have that many babies die. You look at that, that's 519 babies, and that's 0 to 1 year of age in a year. That's a lot of babies to lose, a lot of toddlers to lose. But 87 of those were deaths attributed to unsafe sleeping environments or co-sleeping. So 87 totally preventable deaths. More than one per county in the state of Alabama. There's also another 6 additional deaths that were related to suffocation or strangulation, possibly. So I think that there is a huge burden of education that is on our backs to try to help these babies or help these families learn the right way to put their babies to sleep. And it seems very obvious to most of us that that is what we should be doing, but there are lots of people out there who are not connected, who don't have huge family resources. There are children who are 16 and 17 years old having babies, people who are suffering sleepless, trying to figure out a way to get this baby to go to sleep, and they're getting lured into unsafe environments for their babies. And I think that the only way we change that is to repeatedly present the message. And that's back to must be present to win. We have to be doing it every day, every time with every baby. So here's some of what's gone on in the state as far as trying to help change this situation. There is a monitoring system that's called PRAMS, this Pregnancy Risk Assessment Monitoring System, and a survey in 2011. And I think PRAMS is Alabama Department of Public Health partnering with the CDC. And these are randomly chosen mothers after delivery who are given the survey. And in a 2011 survey, 66% of healthy full-term infants were placed on their backs to sleep. Yay! That's great. But that means that 35% of them were on their side or their stomach. So there's a huge place to make improvement there. Healthy People 2020, the objective there is to increase back sleep positions to 76% of healthy newborns. I guess that's good, but to me, it seems like we want it to be 100% of newborns to be on their back. And I know we have to measure our progress gradually, and it is a long race, and we're putting one foot in front of the other and showing up. COIN is a collaborative improvement and innovation network to reduce infant mortality. It is present in the state of Alabama, directly related to an infant mortality summit that was held by Public Health Regions 4 and 5 in January of 2012 in New Orleans. At that summit, there were 13 states present, and each was charged with the job to develop a plan to address infant mortality. The Alabama plan was called Blueprint for Change. And after that, I believe the COIN initiative was launched in Alabama. So what COIN is supposed to do is support collaborative learning, innovation, and quality improvement efforts to reduce infant mortality and improve birth outcomes, to apply evidence-based strategies to reduce infant mortality, and to stimulate action across states. In Alabama, I think the strategies for COIN were 5-pronged, and I think Alabama is one of the few states that is addressing every finger on the hand. One is to reduce elective delivery prior to 39 weeks. Preterm delivery puts you at huge risk for lots of things. The 37 to 39 weeker even puts you at risk. I just went to a meeting where one of the speakers talked about brain development in babies who are 36, 37, 38 weeks. And that 35-week to 40-week time in the gestation is incredibly important for brain growth, and brain maturity, I am sure, has quite an impact on how well a baby deals with a sleep position. The second was to expand access to interconception care. The third is to promote smoking cessation, because as Dr. Wagner has already pointed out, that is an important factor related to sudden unexplained infant death. Obviously, infant safe sleep, that's what we're here talking about today, and then improving perinatal regionalization. So the Alabama COIN initiative has established a safe sleep team, and I believe there are hospitals throughout the state who are participating in this effort, all the delivering hospitals actually in the state. Alabama COIN also has established a website and developed a safe sleep survey that's sent to all the delivery hospitals in the state. I think in that survey, to find my stuff, 47 of 51 hospitals completed the survey. 64% have a safe sleep policy in place. 40% had a formal safe sleep policy and conduct annual competencies, because you can teach everybody one time what safe sleep is and the things that we're going to message while the baby's in the nursery. But any of you who've worked in a nursery know there's a lot of turnover. The nurses change, the doctors change. It's hard to keep all the kittens in the basket in terms of making sure you've covered all your bases. So annual competencies are very important for maintaining the policy. 98% provided verbal instruction about infant safe sleep prior to discharge, and that's great. I think verbal instruction from somebody at the time of discharge is extremely important, but only 68%, well no, it said 68% do not ask where is that baby going to sleep when they go home. And I think that, is that correct? I think that's right. That's what I was given as the response to that survey. So there's a lot of us not asking, where is this baby going to sleep? And many of us probably feel like, well, maybe that's not my business. And I think that what it does when you ask, where's your baby going to sleep, you're engaging the parent in discussing how are we going to sleep when we get home, and emphasizing how important that is. I think that babies go home with a mom and a daddy who've spent a lot of time painting the walls in their nursery. They've gone to a few showers, and some of the most lovely things you get at a shower are these beautiful blankets and all these stuffed animals, and they've spent lots of time creating the cosmetic environment for their baby, but they may not have created the safe sleep environment. And I think for people who are in poverty, that addressing a safe sleep environment and discussing with that family that, you know, it doesn't have to be a fancy crib. You have to create a safe place for your baby to sleep, and that cannot be in the bed with you. I think those are really, really important questions to ask at the time of discharge, and I think a nurse at the nursery, at the hospital needs to do it. I think the pediatrician or the neonatologist need to do it, because they need to hear it on a number of levels. In addition, Alabama COIN also collaborated with the Alabama Child Death Review System to update their brochure, their Safe Sleep brochure. They also are working with Children's Trust Fund and Alabama's Cribs for Kids program to help people who qualify to get a crib. In January of 2014, the ADPH and the National Governors Association had a conference in, I believe, in Montgomery. And at that conference, there were hospital staff, providers, and stakeholders present to discuss implementation of measures to address infant mortality with safe sleep as the area of focus. There were 27 of 50 delivering hospitals, and I remember asking why were there only 27 hospitals there when there are 50 delivering in the state. Someone told me that it was because it was a fairly short notice in terms of the planning of the meeting, and that not every hospital was able to be there, not because they weren't interested. Dr. Michael Ramsey, who is the president of the state AAP chapter, reviewed the safe sleeping environment for infants as stated in the AAP policy statement. And that at that time, work groups were established to develop policy and competencies for all staff. So I think the hospitals are now in the process of presenting their policies or developing their policies. There are not safe sleep champions in all hospitals yet, but that is a priority of the American Academy of Pediatrics. At our board meeting last week, basically, we felt like the way that we could help with this is try to identify pediatricians or family practice people in every delivering hospital in the state who will take on that job to help promote safe sleep. Now, in the real world, where are the barriers? I think that most of us who practice pediatrics will tell you the biggest barrier is time. I have poverty up there as a real world issue, and it is. However, I think the safe sleep messaging from how do you deliver it and when do you deliver it, the time limits within an office, in a nursery visit, a prenatal visit, the first visit in the office, those time limits are overwhelming sometimes. I think, though, if you really get down to it, this is a message just very brief. It's not like having an immunization conversation with a parent, which can get extremely extensive, and they can give you lots of what if. I think the back to sleep message, there's really not a good argument for it. And so it's basically reinforcing to parents one more time what they've heard before. I have parents who ask permission to put their babies on their tummies. And they'll come in at 2 to 4 months of age and say, you know, he just sleeps so much better when he's on his stomach, and I have to have some sleep, and please tell me it's okay if I put my baby on their tummy. And I said, no, it's not okay. I think if you think about it and you look at all of the information that we have available, and you go home and you put your baby to sleep on their tummy, and they had an event that resulted in a death because you put your baby down to sleep on their stomach, are you going to live with that? And I've never had a parent who tell me, well, I'm taking the risk anyway. Not one. Because I don't want that on me. I don't want that on them. I feel like what you live with the rest of your life, that's one of the things you just have to say, I'll have to suck it up, and we're going to have to lose a little sleep right now, and we'll do without, and my baby's going to sleep on their back. Grandparents pushing back, well, I'm in the age now where I'm a grandparent age, unfortunately. Life just rolls by really fast. And I think the grandparent pushback in my age group is basically related to, well, that's not how my baby slept. And I think I think most grandparents that I see are really willing, way above where maybe a generation ago they were like, I'm the grandma I say and what I say goes. Now I think grandparents are pretty sophisticated, very educated, and really want to try to do right. And in many times they think they may be more well informed than their children are as far as what is a safe thing to do. The poverty, the cribs for kids, there is an application process involved with this. And in the state of Alabama, there are cribs available in certain states through the Children's Trust Fund and the Gift of Life. The counties are listed: Baldwin, Clay, Conecuh, Coosa, Escambia, Jefferson, Mobile, Montgomery, Randolph, Talladega, Tallapoosa. So since 2010, 963 cribs have been distributed in Jefferson and Mobile counties, and the Gift of Life has distributed 1,154 cribs since 2005. I think that's important. However, I think saying that a safe sleep message can't be received and accomplished because you don't have a crib is making, I think, is a wrong statement. So I think that people can create safe sleep environments without the presence of a crib. necessarily. So I think that is important. I think it matters. I think anything you can do to try to take away this 87 kids dying because they weren't in a safe sleep environment contributes to success of the endeavor. When is the time to do this? Every time you have a contact with a patient. The nursery time is very important. The prenatal time is very important. Not many people come for prenatal visits, really. There are a few who do, but the largest percentage of my practice, most of them you meet in the hospital for the first time. So nursery nurses presenting the message, nursery nurses making sure the hospital presents the message in the way that that baby is taken into the nursery. I have a colleague in Huntsville, and what she said this weekend is right. Is kind of like the terrorist thing in New York City or wherever else. If you see something, say something. If someone in the nursery has done something or brought a baby back to the nursery where it's evident that the mother has, or the grandmother or the father has not done a good job of meeting safe sleep criteria, you say something about it. And I think the same thing is true when the pediatrician walks in, and it's true when we meet them for their first visit in the office. I think the discharge teaching ought to include a repeat of the same message that the nursery nurse provided, and the first time they come to the office, which is usually within a week, that message ought to be presented again. I think you can't say it enough. Grandma says, and like I said, now my grandma's not so much, and I guess some of that is because of my age. When I started out, I was, 29 years old, and I had a child, but I certainly wasn't experienced, and I got a whole lot of kickback from a lot of people because I was young. I'm not young now, and I'm experienced, and I don't get intimidated, and I think I communicate fairly well, and am able to have a discussion more than an argument now. But a discussion that is very firm about what is the right thing to do and what is the safe thing to do. We do use these little handouts in the office, which is basically simple, very concise presentation of what a safe sleep environment is for a baby. We started ordering these after our hospital nursery director showed them to me and said, this is what we've decided to use in the hospital. And it's a Eunice Kennedy Shriver National Institute of Child Health and Human Development publication. It's free. There's a Spanish version. There's also a DVD that goes with it, which is a nice 9-minute conversation between a nurse on the playground and several different families that specifically addresses the concerns or the things that people think about sleep. But it does a really good job, and this is what we're giving to our patients at their first visit. So they've seen it in the nursery, and then they see it again from me, and I directly address this. And then I address it again at 1 month when they come back, and I go, now your baby is sleeping on their back, right? Not letting anybody put them down on their tummy. Remember, that's the wrong way to do it. And I think I do a decent job, and then, a day before yesterday, I get a call from Children's Hospital for a baby who's discharged because the mother put the baby down on its belly, and she went out to play with a 2-year-old and came back in. Something just told her to come back in, and of course the baby was blue and not breathing, and she did CPR, and he was admitted at Children's for a few days. So I think I do a good job, and there we go. She had a near-miss event and was discharged home with a wonderful, happy, smiling, great little baby who I saw yesterday afternoon, and he looks great. But I talked to the mother again about, prone sleeping. So we just have to keep plugging away, and thank God that child is okay. Co-sleeping, I think you specifically address. I think that is probably a bigger problem for my practice than prone sleeping. I think people who breastfeed, a lot of them get really tired, and they are looking for just a few extra minutes, or the mom does fall asleep while she's breastfeeding, and I understand how that can happen. I have been there, but that's where they need to have a partner who helps and takes that baby and puts them back in the bed if she's that tired and tending to fall asleep. I think that co-sleeping early, other than increasing your risk for SIDS, also increases your risk for problems with sleep later on. And at some point, you got to just cut the cord. And I think if you encourage parents to avoid co-sleeping early, you can tell them they get a big payoff later. Not only do they reduce the risk for infant death, but they get a huge payoff with sleeping issues later. Special needs children, I think Dr. Wagner pretty much covered these things. The preemies, the GE reflux, the developmentally delayed, they all need to sleep on their back. There's really, I can't think of one exception that I've taken care of who was a baby who needed to be in a prone position. So, as we've already discussed, you do the things to keep your baby healthy too. Good prenatal care, early and often. Well baby care, which includes all the immunizations according to the schedule. Breastfeed, breastfeed, breastfeed. You can offer a pacifier for sleep. And I think that it needs to be after breastfeeding is well established before the passy comes into the picture very much. What to avoid? Overdressing. I have some cultures. There are some families in Montgomery who live in apartments and they keep their apartment 80 to 85 degrees. I don't know how they are able to handle that, but I do think babies wilt in the heat. They don't do very well. And I think that for the most part they ought to be 68 to 72 degrees, and my father thinks that that is the Arctic when he comes to my house. But you know, I'm in that hormonal age group and it really feels good to me. A baby likes it too. Long-term swaddle I think is a bad idea, and I think that generally in this part of the country the swaddling is used widely. People use it to comfort their babies and to give them to give them less reason to cry, I think. And I think swaddling's fine. Probably 6 to 8 weeks is about as long as they ought to be doing it, because developmentally after that, it's just putting them at high risk to have a problem with the swaddle. The sleep positioners we've already discussed should be avoided. I've just talked about the thermostat, kind of skipped ahead of myself. And any commercial product that claims it reduces the risk of SIDS should be avoided. So here's the place where I'm going to say, I think any of us who went into healthcare because we wanted to help people. And a lot of us who went into medicine early on went into medicine. I went into medicine thinking I wanted to be a family practice person. And then I decided I wanted to be an internist. And then, thank heaven, a divinely inspired moment presented itself and I became a pediatrician. When I trained, we spent a lot of our time in the ICU. A lot of time treating H-flu meningitis. Very exciting, very fulfilling. You save a life. You know, it was so gratifying. Through the years, we've immunized ourselves out of that opportunity. And a lot of people may not get the gratification now that they thought they were seeking back in the day. Because really what my practice has now boiled down to is I feel like I help families grow. I feel like I keep children safe. I try to prevent disease and promote health. And I think in a lot of ways, sometimes when you do that every day, you feel like it's a wonderful life. Okay, I'm not sure what difference I'm making. And I think all of us have to sit down and think about the difference that you make, you may never know. And this is one of those things that takes a few minutes to do, requires no financial investment on anybody's part in terms of spending that extra few minutes, and you're saving a life. So it's an important thing to involve yourself with. It's an important habit to develop so that every time you're asking that question, and I believe that it gives you great return. So those are the things Alabama's doing. That is how I support it. And now I'm asking you, do you have any questions?
a couple of questions that have come in over the internet here, so we'll just start with the first one. It says, how are these exceptions to this rule of having babies sleep on their back? Are there exceptions to the rule of having babies sleep on their back?
I would say no. Do you think of an exception?
I would say no, unless there was some extreme medical condition, and one I alluded to was children who have reflux, who have a laryngeal cleft, and they aren't able to protect their airway. But that would be something that would have been evaluated by specialists, and that you should actually discuss that with the specialist. That should not be decided between the babysitter, grandma, mom, and Oprah. Okay, so I think that the answer is no, very rarely. But that should definitely be something that you would address with your primary care provider. I think asking that question is a very good question.
How old are babies who die from SIDS?
So the biggest risk is probably between the ages of 1 month and 6 months, highest between ages 2 and 4 months. It's very unusual in children over 8 months. It was thought to be unusual in children less than 1 month, but in the recent statistics, 10% of children were under 1 month. So really the risk drops off primarily after age 6 months. But they can be any age. Up through, I would say, once we get... The reason the death scene investigation and autopsy and all those things are important is so that we actually try to figure out, was there an underlying disorder, was something that, and that helps the family get closure as well. But also, is there something to be looking for in this family, in this environment? Is there an underlying disorder that needs to be treated? I think that those things are important. But really, pretty unusual after 6 months, particularly unusual after 8 months.
The third question we had come in is it a myth that a baby will get flat spots on the back of the head from sleeping on his or her back?
The answer is no.
It's not a myth, and they will get flat on the back of their heads, but once they're learning to sit up, all of that rounds out. It's really just a positional issue, and then once they're sitting up, they round out.
Which is why tummy time is recommended in terms of on a regular basis, and not only does that help the positional plagiocephaly, but also helps the child develop, helps the child, strengthen, and also gives you an assessment of how is that kid doing with head control and holding their head up, and they learn to roll over. Once they can roll over, remember, we don't have to go back and put them into the supine position, but it works on them developmentally and helps their strength.
The last question we had come in is a 3-part question. The first part is the side position as effective as the back sleep position in reducing the risk of SIDS?
The answer to that is no.
Second part, will babies choke if they regurgitate or throw up while sleeping on their backs?
So that has been a question that's been raised, and most babies have adequate airway protection. And in fact, when they're choking, they are responding to whatever is reflux or whatever is stimulating their choking, and most infants will not have a problem with that. There's no evidence that putting kids who have reflux in the supine position increases their risk of aspiration.
Last part to this 3-part is, will electronic cardiorespiratory monitoring prevent SIDS?
The answer to that is no, and we've known that for years. We've been using cardiorespiratory monitoring for a long, long time. Hasn't altered the risk of SIDS at all. Right? And the problem is that most kids who go on to die from a SIDS event never had a previous event, and so there's no way to predict. I think much less so now, but when I was a resident, again back in the dark ages, we used a lot of monitors.
And they just aggravate parents.
Yes,
what they do.
and they don't do anything to prevent SIDS. That we are identifying the correct group of children, and they do make people crazy. And actually, we have one of our nurses who tells a story about a mom who called her desperately because the monitor was going off with loose lead alarms and driving everyone crazy. And she said, well, where is the monitor? Because you can't turn it off. And she said, it's in the trunk of my car. because it was driving everyone so crazy.
Place for it.
So, you know, we do send kids home on monitors, but with fairly specific reasons. And I also believe that when we send kids home on monitor, we need to have an endpoint in mind. We don't just put kids on monitors and say, see you later, check in with us. We need to be thinking about why do we put that kid on a monitor. So if a kid leaves the nursery on a monitor because they're premature, there's an endpoint at which time we think that they are mature enough that we can take them off the monitor. We also have monitors that we can actually review monitor alarms and see, is this child having events? There's also a huge study looking at extreme events in infants who have been monitored for a long period of time, and most of those episodes are resolving by 44 weeks post-conceptual age. So we do not put kids on monitors routinely. We do in special circumstances, but those special circumstances, we have an endpoint in mind.
I believe we have a caller on the line from Madison County. Caller, are you there?
Yes, I am. We're interested in getting the Cribs for Kids program started here in North Alabama. Looking online has not really been very successful for me, and I'm wondering, who do I contact?
How about I'll figure that out for you? If you
Okay.
could give us your information, and I'll try to find out who you can contact.
I'll be glad to. Thank you.
Thanks. Should I take that now?
They'll take it for you.
Okay.
Are there any questions from the audience? Yes, ma'am.
Is there a particular message that you find helpful to help parents remember, like the ABC for sleep, alone on the back and in the crib, or another type of...
Oh, I like that. I
yeah.
like that too. Maybe I'll use that one.
Or another type of kind of trick to help parents remember, or a specific phrase that you use to help them remember or help them teach other people?
I don't use a specific phrase. I like that one, though. I do talk about infant mortality. I think it's a scary thing when you use that number and you put up, hey, this is what can happen. And ABC, though, sounds good. I think I could probably incorporate that.
Any other questions?
About how long, just in your private practice, which is so busy, about how long do you think it takes to deliver a safe sleep message to families? Because that's such a challenge for private pediatricians to work in one more thing in a already crowded visit.
I think that, I think probably in the first few days, that's probably the most important message you can deliver. And I think once you've talked about the breastfeeding and how that's going, because usually by that 3 to 5 day out mark, that's critical territory. They're either going to keep doing it or they're not. I think the next thing to talk about is the sleep and how that's going, and then work into the safe sleep. I don't think that takes that long, but I think you have to be somebody who's done this a lot and kind of just make it one of those things where you start talking when you walk in the room and you allow the parent to talk too. I don't mean that you're teaching down to them the whole time, but you're having a conversation about the sleep. Because I think sleep is probably the first question I ask outside of feeding, and generally then you can work into that.
Yeah, I think the other thing to remember is that babies spend most of their day asleep. And so we don't really want to be putting our baby that's spending maybe somewhere 16 to 20 hours a day asleep in an unsafe position or an unsafe situation. And I think we have to remind our families how much time children spend asleep in that first couple years of life and how crucial that is in terms of safe sleep and appropriate sleep.
We have another question that came in through the internet, and it's from Patsy at East Alabama Medical Center Prenatal Clinic. And her question is, can infant twins sleep in the same crib?
And the recommendation is no, they should not be sleeping in the same crib for a couple of reasons. What we don't want to have happen is those kids impairing each other's sleep. But again, studies have shown that kids that are co-sleeping, and remember I said that one of the risk factors for SIDS was multiple people in the bed even a sibling, okay? So it doesn't have to be a huge sibling, but we need to make sure that there's attention to supine positioning, making sure that the environment is that you can't snuggle up against the other person, and that's one of the issues in terms of suffocation or sudden unexpected infant death. It's not just about SIDS, it's also about can the baby be put in a position where there is a suffocation risk? So the answer to that is no.
Any other questions from the audience? Go ahead.
So you mentioned that getting a baby to sleep alone in a crib or bassinet from the beginning can help prevent future sleep problems. What kind of future sleep problems are you?
Oh,
Here's a sleep expert. I'll tell you as a primary care person what kind of future sleep problems, and then she can lead on. But I think that you're training your baby to sleep in an environment, and you're teaching your baby, this is how we sleep, this is where we sleep, every time. And initially, yes, from a personality standpoint, whether it's the mother's personality, the daddy's personality, or the baby's personality, or the mother-in-law's personality, somebody inherently, affects that baby's personality and their temperament. And so those babies who are really highly charged and demand that you do this, and then you do this, and then you do stand on your head, you do whatever you can to get the baby to sleep. And a lot of those people end up sleeping with their babies. And then the child is conditioned to sleep in that environment. Number one, it's not safe. So we know we're not supposed to do it for that reason. But if you look at it from a long-term standpoint, the investment in sleeping in a crib by yourself on your back without a whole lot of cues, the payoff for that is huge later. One, you have reduced your risk for having an infant death. But two, what you're doing in age 3, 4, 5 is huge, huge. Because to me, that's one of the most common questions I get from parents of toddlers is, how do I get my kid to sleep?
How do I get my kid to sleep? Yeah. So when you have to do that, that's called sleep onset association disorder. And what we try to teach our families is however you want that baby to go back to sleep at 3 o'clock in the morning is how they should go to sleep at 8 or 9 at night. So if you don't want to be in there rocking, holding, singing, playing, dancing.
In the car riding around.
Right, or in the car riding around, then the kids need to learn to go to sleep. And going to sleep seems to be a highly charged issue for a variety of reasons. But when we see that pay off or not pay off is when they're in Dr. Troxler's clinic or my clinic when they're 2. And mom is exhausted because every time the kid wakes up during the night with normal arousals, she has to go in and rock or soothe and get the baby to go back to sleep. Right. And so then mom has had 2 years of, the complaint is the baby never sleeps, is what the complaint is. What actually is happening is the baby requires some kind of association to help them go to sleep. And we all know that 2-year-olds should not be up at night running around the house. They should be asleep in their cribs. And in fact, it's much easier to teach them from the start than to try to recondition them when they're ages 2, 3, and 4, because once they've learned to climb out of the crib, you're hosed for a while.
Right. And they can talk too.
Yes.
Have an argument with them.
That's right. And that will comes into play.
Mm-hmm.
So teaching them to go, not only is it safe, but it is also appropriate, and it is also appropriate for parents to get sleep. When parents don't get enough sleep, it is very difficult to deal with a crying baby or an insistent toddler. So getting good sleep for parents allows them to be better parents. And I think that we shouldn't misconstrue that being a good parent means that you're hovering over the child and that you're physically attached to that child 24 hours a day. You need some time to do your own thing. Parents need time to recoup. Otherwise, they're not going to be able to deal with that crying infant or that toddler who doesn't ever seem to sleep.
We've got another question that's just come in, and this is from Jessica at UAB Newborn Nursery. And the question, it says, well, it's kind of a statement. The UAB Nursery has really pushed the back to sleep with good results, but we are finding that other aspects of safe sleep are not emphasized enough. If you were to pick a second area to focus on that would have the biggest impact, what would that be?
Well, I think behaviorally, we know that in terms of risk for SIDS or SUID, it's actually breastfeeding. Breastfeeding is probably the thing that has been most effective. That is sort of a personal choice, and as Dr. Wood pointed out, it has a lot to do with maybe how you were raised, maybe some misconceptions about breastfeeding, but I think also nurseries and hospitals are very good at having breastfeeding consultants who are tremendously good at helping people problem solve for that. But I think if you're looking at that environment, the baby should be sleeping on a mattress that's fitted to the crib or the bassinet, and there should be nothing else in there, basically.
We still have a few more minutes left in the program, so if anybody who's watching has any questions or comments, I want you to feel free to give us a call or send us an email. I think what you were saying was really important about in terms of the sleeping thing with the moms, because one of the things that I find among my friends is once they actually get the kids to sleep on their own, they find that they sleep a whole lot better in their bed because it's not a hand or a leg coming out hitting you.
Absolutely. You put them in their crib and they're safe in there. They don't really need to be in your bed with you, and it's just very disruptive. Right. The other thing that we sometimes see is sometimes adults are doing things at night that disrupt children's sleep. So if mom and dad are going to sleep with the TV on, a lot of times the kids will sit up at 2 o'clock in the morning. I haven't seen that. I'll sit there and watch it. Or sometimes parents have obstructive sleep apnea and they're snoring or kicking, and that can indeed disrupt the kids' sleep. So everybody needs their own space, and everybody needs their sleep. Kids spend a lot of time in sleep, and it's probably very important, particularly for infants, for critical reorganization of information that they've obtained during the day. So they're taking what they've learned during the day and they're
filing it away.
They're filing it away. They're defragging the disk at night and incorporating that information. But it's also important for parents, too, in terms of, as I said, to be able to deal with the rigors of taking care of young children. I've been on call my entire life. I've been a resident. Mommy call is far harder than any call I ever had as a pediatric resident or fellow. It never stops. And so it is important for mommy to get some sleep, or daddy.
Do you have any recommendations for how long a baby should sleep at daycare? When the parent is introducing them to the daycare and they're going to be in that environment and you're talking with the caregivers about, hey, they go down for nap at this time and they'll be asleep for however many hours before it's playtime again. Is there any recommendations for that?
I think it depends on the kid's schedule, really.
I think most daycares pretty much have this thing where, if you think about it, they got 2 caretakers, 10 kids in a room, all toddlers. They're going to try to get everybody down at one time. Right. And most daycares, it's an hour and a half to 2 hours of sleep in the morning, and maybe for the younger babies, children less than 1, and same in the afternoon. But for the toddlers, most of them are in the middle of the day nap, and probably 2 hours. That's what I see here. I don't know about other places, but newborns, they're going to sleep all day long. Yeah. And that's, and if you have a home sitter who's decided to sit there and rock them all day long, that's going to be a hard job for you to break that at night.
Right, and that's another one of those situations where, as the parent, you should be guiding what's going on in that daycare or at a sitter at your house or even at grandma's house in terms of...
Yeah, some grandmas will rock them all day long.
This is how we put them to sleep. Don't make my life harder, okay? Right? It's okay to spoil the kids when they're, 4, 5, and 6, but teaching that, we shouldn't be doing that for little infants. We should be teaching them to sleep the right way so they get good sleep habits. They learn to fall asleep on their own so that when they have normal arousals or awakenings during the night, they know that they can go back to sleep by themselves, that they don't need external influence. They don't need somebody to rock them. They don't need a breast in their mouth to go back to sleep. They learn to go back to sleep on their own, and that self-soothing behavior is very, very important.
Any other questions from the audience?
You mentioned the Cribs for Kids program, but also the corollary is you don't need a crib to have a safe sleep environment, and we talked a little bit about that early. If you just want to elaborate more on that.
Well, that was the thing I guess I forgot to kind of incorporate as I was doing it. But as poverty and Cribs for Kids sort of restriction, and because you don't have a crib, you can't provide a safe sleep environment for your baby, I do think that poverty impacts sleep messaging, or it increases your risk for having a sudden infant death or a sudden unexplained infant death. But I think it's really a poverty of information or a poverty of education, and not so much because there's not a crib present. And I think that is really our highest risk group is the group where you are concerned that this baby is going home with a family or a mother and no family who has very limited support from an information standpoint. And I don't think that you have to feel like because this baby doesn't have a proper crib that they can't have a safe sleep environment. And I've been in Finland. They send babies home with boxes that are from the hospital, safe sleep environment, and they offer mothers either the money or the box. And the box has huge things in it that support infancy. But part of that message is that this baby has a safe place to sleep. It's a flat surface and I assume a small mattress or with a crib sheet, and that you can create in a lot of ways, or that are outside of the quote baby bed.
And some of it is just avoiding things that we know are associated with unsafe sleep, like sleeping in a bed with an adult. I mean, that's a no-no, you know, and that eliminating tobacco exposure from the environment, if possible, breastfeeding. Those are things that don't require money. They require, you have to plan.
Education and
and the importance of those things, and the importance of being an advocate and insisting that environment will be the environment for your child, rather than, oh, well, you go to this person's house and, you know, we do things differently. That's not the way it should be when it's for safety issues. You know, it might be if grandma's going to give dessert before dinner, but grandma shouldn't be deciding that, yes, we're going to sleep on the couch.
It's car seats and safe sleep.
Yes.
I mean, those are places where there is no room for negotiation.
Right. So I think that you just have to be thinking about all the different aspects. Yeah, you might not have a crib, but you can certainly avoid things that we know are unsafe.
Are there any other comments that either of you would like to make before we conclude the program? Putting you on the spot.
Good.
Well, thank you so much, Dr. Wood and Dr. Wagner. I've certainly enjoyed the program, and I'm sure that it's been very beneficial for our listeners. And thank you for joining us on the Alabama Training Network. I hope this program has been beneficial for you as well.